Good morning, everybody. Hey, I was just making a comment. You guys actually look good for a Monday morning. Why are you so happy on a Monday morning? Spring break's on the way? Is spring break? No, it can't be next week. You've got an exam next week. Oh, you have a 2-day spring break. Yeah, uh-huh. Okay, so what we're going to cover in the first hour is phosphate, calcium, and magnesium regulation. We've covered sodium and potassium. Now we're going to cover these. And let's start with a case. 7-year-old boy complained of fatigue, thirst, and increased frequency of muscle weakness and tetany during the previous 6 months. He was not on any medications. A blood workup revealed normal calcium, hypokalemia, hypomagnesemia, and elevated bicarbonate. The resident told the attending that he suspected Gitelman syndrome or Barter's syndrome. And the difference between these two is that Gitelman's is kind of like thiazide. It's a defect in the sodium chloride cotransport in the distal tubule. And Barter's syndrome is a defect in the loop, much like furosemide, or at least it has effects that are mimicked by furosemide. The one thing that's interesting about these, although they have very similar characteristics and can often be confused for each other, there are differences in the way they handle calcium. And that's why that last comment there, the attending told him to order urine electrolytes and pay particular attention to the calcium. So I'll go through that in just a little while, but that just gives you a hint. You know that there are certain diseases that we address in physiology that are kind of tied directly to some of the mechanisms. And so when it comes to doing step 1 exams, they kind of might like you to know a bit, certainly about diuretics, but maybe about some of these named syndromes that are associated with defects in particular sodium transport mechanisms. So I'm not big into using names. I kind of like to show you what's wrong and then have you figure out why it's wrong. But I know the STEP exam may do that, may ask you to remember names. So let's start with phosphate. About 85% of phosphate is reabsorbed in the proximal tubule. And in most circumstances, somewhere around 15% is excreted. Remember that I told you that we tend to have a lot of phosphate, and so one of the issues is that we have to get rid of it. So in general, 15% of the phosphate that's delivered to the glomerulus is excreted, plus or minus depending on, diet. Some textbooks say that there may be some phosphate reabsorption in the distal nephron, but that's not been well characterized. So let's just keep it simple. 85%, let me rewrite that. 85% reabsorbed thus. And there are a couple of different mechanisms. We have this is 2C and this is 2A. Do you know, I'm not, this one's electrogenic. I'm not too interested in you remembering the details. I think you ought to have a feel for these things, but but the fine details I don't really need you to know. I mean, I guess I don't need you to know that. So this pump, mostly in the early proximal tubule, this one throughout. This one obviously has a bit more horsepower, and so it might be capable of squeezing out more phosphate in the latter part of the proximal tubule when the phosphate concentration starts to fall. Okay, so that's the basic setup. I've also got a note here that realize that the pK of phosphate 6 point, does it tell us, say what? Oh. So at pH 7.4, which is what the tubular fluid is at the Bowman space, it's about 80% of HPO4. Okay. The other 20%, and that's 2 minus H2PO4. The only reason I am mentioning this is that, and this will become important later, the only reason that I'm mentioning this is that the protonated form, this form, doesn't carry too well on these two pumps, and so mostly we reabsorb the monohydrogen phosphate, and this has a utility because later on when we do acid-base balance, we'll need to figure out ways of buffering protons that are secreted and peeing them out. I mean, you can't just pee out acid. You've got to somehow trap it on a buffer, and indeed the phosphate will tend to trap excess hydrogen ions, and then those excess hydrogen ions that are trapped there tend not to be reabsorbed well and will tend to be excreted. I'll go through that again because it's I think on Wednesday, because it's an important concept. Okay. Oh, and at the bottom, I've got a comment. Inorganic phosphate concentration in plasma is approximately 1 millimolar, so it's not a lot. If the GFR falls drastically, then the filtered load of phosphate is inadequate to meet excretory needs. And we addressed that before in a case. I think it was a polycystic kidney disease case, right? The GFR fell so much that the patient could not filter enough in order to excrete what he was eating. And so the plasma phosphate can go up in severe renal failure. Okay. So let's talk about how we regulate this. Just take this off. I have got a diagram there that looks like that glucose diagram. Remember when we showed that if you plot the plasma concentration, so phosphate concentration in this direction, and measure the amounts, basically the 3 graphs, milligram per, is it per minute? What's on that axis? Huh. Actually, that's kind of an error because it has to be a mass, doesn't it? M stands for concentration. Wow. That would be now corrected. So, and again, if that's the excreted line, And I know I'm going through a concept we've been through before, but since it's an important concept, I think it's well worth it. The amount excreted is going to be directly proportional to the plasma concentration and thus the filtered load, right? I'm sorry. Yeah. I beg your pardon, not excreted, filtered. I just said that you guys look good for a Monday. Obviously, I'm not as sharp as you are. Okay, so bear with me. So now the issue here is that I'll have to give lots of candy away if you can catch me out in mistakes. Can you do that? Because this won't be my first mistake, I have a feeling. All right, so let's use a different color. There's a Tmax for the amount that's reabsorbed. And so the excreted amount, like the glucose, what's interesting about this is that the point of inflection here is about the same as the plasma concentration. And so what this means is if the plasma phosphate drops, sort of automatically you're going to get 100% reabsorbed. Let me go through that again. If you're on a low phosphate diet and the plasma phosphate drops, you'll be on this part of the curve and you can reabsorb just about 100% of the phosphate, which is good because you're deficient. If you've got too much phosphate on board, the plasma phosphate goes up, you'll come to this part of the curve, and now you see you pass the Tmax and you'll get some spillover, okay? So to some extent, there's an automaticity in being able to get rid of the appropriate amount of phosphate just based upon the being at or around the Tmax. Make sense? This is an old diagram, 1944. But the facts don't change, so it's good. The other thing is that if you're on a low phosphate diet, you can raise the Tmax. In other words, you can synthesize some of these transporters that we just talked about, and it will tend to increase the Tmax, and you can reabsorb more phosphate. And conversely, if the reverse is the case, then you can also go down this way. So those are aspects of phosphate regulation. At the bottom of the page there, I've got kind of a tedious list. And in some ways I apologize for it, but it seems like the step exams get kind of excited about phosphate and how it's handled. And I thought that it would be proper to put a more complete list in. And I probably ought to reorganize it at some time. First, let's use a different color. Parathyroid hormone, can I just write up PTH and you'll know what it is? It inhibits the reabsorption and it has a profound phosphaturic effect. So, what stimulates parathyroid hormone? Low calcium. And you're thinking, okay, why would that be significant? And I'm not writing in valencies. So, why would it be advantageous if you've got low calcium to turn on parathyroid hormone and affect phosphate? Well, you already know that low calcium does actually stimulate parathyroid hormone to do stuff with calcium, but also phosphate reabsorption. So if parathyroid hormone causes phosphate excretion, this goes down and the reaction goes in this direction. Okay? So phosphate loss is actually a way, at least immediately, of bolstering the low plasma calcium. And we'll go through this in endocrinology later on as well. There are also some direct effects. High phosphate well, kind of works in reverse too. If the phosphate levels go up, then the reaction will go in this direction, and that will go down and you'd stimulate parathyroid hormone. There is also another effect. High phosphate also stimulates a substance called FGF, fibroblast growth factor 23. And I don't think this is in Costanzo yet, but it's in a lot of other books. FGF 23 also inhibits phosphate reabsorption and interferes with the system here. Okay. So what have we missed out here? So parathyroid hormone we've covered, phosphate loading, we've done the solubility product, we've done the FGF23. The next two is basically what we did with that graph. Acidosis, we kind of touched on that. In an acidosis, phosphate will tend to be liberated from bone. And as such, in an acidosis, plasma phosphate levels will go up, they will be filtered, and then in an acidosis they're going to combine with the acid that's secreted in the tubule, and then the acid and the phosphate get excreted together because they're trapped. Do I need to write that up on the board or just say it one more time? It's good? You guys are sharper than I am this morning. Big pardon? I will say it one more time, yeah.
So, I know you have an acidosis and you have high phosphate levels. Will the phosphate combine with the hydrogen in your blood before it gets built at all?
Yeah, so the question is, will the acid combine with the phosphate in the blood? And yes, that's true, because the balance between monohydrogen phosphate and the dihydrogen phosphate is dependent upon the pH, or the amount of hydrogen ion. So yes, there will be more acidified phosphate, in the plasma. Well, and it'll still get filtered, but it won't, it won't get reabsorbed. And so the protonated phosphates will get excreted, and any non-protonated phosphate, as it passes into the tubule, it'll combine with all those protons that are secreted in the proximal tubule, and so you'll make even more protonated phosphate. The phosphate then has trapped the protons, and the protons get excreted. and that's the way the kidneys handle acid. We will go through that in glorious detail on Wednesday, okay? But that's just kind of a lead-in. And I know the boards have said a question on this before, volume expansion. So if you have volume expansion, you reduce sodium reabsorption, and therefore you reduce phosphate reabsorption, and therefore more phosphate gets excreted. I don't know why they get so excited about that, but it's something you probably ought to know about. And finally, cortisol. I don't think we need to say much about that right now. Okay, sorry if that was a bit bitty and detailed. I probably need to find a way of making that more digestible, don't I? Yes. No. Was that easy? Nah. I'll make it more digestible the next time I do this. All right. So any questions on phosphate? Where? I heard some. Yes.
Could you please address this is 80% and 20% on your notes? What do you mean by 80%, 20%?
Oh, let me. So the question is, where is it? Okay. So the pK of that reaction, if I remember rightly, is about 6.8. So at pH 6.8, you have 50% of this and 50% of this. And I think this was pH 7.4. At pH 7.4, you'll have 80% of this and 20% of this. So this is acid-base. Do you still do acid-base in biochemistry? Wow, you don't? Gosh, it's kind of, I bet you do somewhere along the way, but I know that that was a long time ago.
I think they assumed that it was like left in undergrad. But
So this is, you know, it's interesting you say you think that they covered it in undergrad. I mean, this isn't an incredibly simple concept, is it? I mean, we're all pretty smart people, and yeah, maybe they should cover it a little more.
I guess it was
But it was what?
I think they said it was like in a handout or something. Like a review handout that you go over.
Okay, if you like. If you like. Okay, so you can go to medical school and you can learn some physiology if you like. I am a horrible cynic, am I not? I'm sorry. Scratch that on the recording, would you please, Jerry? Since anybody in the world can hear what I just said, I am now incredibly embarrassed. Okay. We like to have fun, but it's going to get me into trouble one day, isn't it? Okay. So let's. I got your question, right? This question.
Did you answer my question?
I thought I did.
I thought you did not.
Okay. Oh.
Well, at least I did not get an answer yet.
Okay. Let me talk slowly and stop laughing, and maybe we. So,
Okay, I think I got you. You're saying like at pH 7.4, most of the phosphate form is in the mono
Right. Yes. And realize, okay, so at pH 7.4, this is about 80%, and this is about 20%. Okay. So in other words, under the more alkaline conditions, this equilibrium shifts in this direction. Okay? Yes?
And then those 80% all got reabsorbed, and then those 20%
Okay.
like our body doesn't like it, and then it's excreted.
So initially, when you filter, the plasma, you filter it. It's probably about pH 7.4 in Bowman space. Okay. So in Bowman space, most of it's this. This gets reabsorbed pretty well. As you go down the proximal tubule, the pH can actually drop a little, but not a lot. And in the proximal tubule, it can actually get down to about pH 6.9. But most of it, a lot of it is still in this form, and so it can be reabsorbed. Okay, if you get terribly acidic and move in this direction, you make more of this and it doesn't get reabsorbed so well. Added to which you have protons being secreted in the proximal tubule and latching onto this phosphate and go into this. Okay, we'll cover this again later. It's sufficiently important that it'll be worth covering twice. Let me move on to calcium, if you don't mind. If you've still got questions, I'd be happy to answer them afterwards. Calcium and magnesium, and I'll draw, let me just erase this. And I'll do one for calcium, and then I'll do one for magnesium. So 67, 25, and 1. And actually, I can also do the magnesium. So red is calcium. Magnesium, I think about 30% here, about 60% here. What have we got? 90. Probably about another 5% here, and probably 5% excreted. Remember that cells have a lot of magnesium. And so when we eat plants or meat, we do take in a lot of magnesium. And so under normal circumstances, we have quite a bit of magnesium on board, and so it gets excreted. If you ever become magnesium deficient, then you have issues. But under most circumstances, we will excrete probably about 5% of it. So that's the way it's handled in the nephron. I've got just a little aside on filtration, and I'll go through what's going on at the cellular level in just a minute. But let me do something. And it's a bit of a digression, but it's something that you probably need to understand. So the filtered load of calcium equals that. So that's the filtered load of calcium. However, calcium, let's say it's about 40% protein bound. We always measure total calcium in plasma. We can measure free calcium, but we usually measure total. And so it's that times 0.6 if you want the filtered load. And I just do that at this point because it's a possibility for a question coming up. Do I need to go through that again? Only 60% or 0.6 is free, so that's the only part that can get filtered. So the filtered load is the glomerular filtration rate times the total calcium times whatever is free, the fraction that's free. Yep. Okay, let's do some pictures. Let's start in the proximal tubule. So this is the prox. And remember, you've got a whole bunch of things in the proximal tubule, but one of the main ones is that. You've also got, towards the end of the proximal tubule, you've got chloride that goes through a paracellular route, like so, and calcium tends to follow. Actually, calcium and magnesium tend to follow. And again, if this is correct, this is 67%, and this is 30%. Yeah, prox. Is it not in the handout? Oh yeah, so it's panel A. And I'll go to panel B in just a while. It's panel A. And one thing that perhaps we don't always realize is that there's a phenomenal amount of calcium and magnesium that's reabsorbed in the proximal tubule. It's not regulated, but it's a lot. There are no specific mechanisms other than this passive movement that follows the chloride movement. So in other words, the reabsorption of sodium in the proximal tubule and the chloride that follows actually entrains the passive movement of calcium and magnesium by a paracellular route across from the lumen into the interstitium. Okay? So it's a lot. And it's all moving down an electrochemical gradient by a paracellular route. Okay? So now, that second diagram, I better make sure, yep. That second diagram, we're now in the loop. And you have this fella here. Remember, we noted that a lot of potassium leaks back here to make this positive. And so positive ions then tend to want to move in this direction. So calcium and magnesium move by another Claudin in this direction, again by a paracellular route. And these figures should match up. 25% for the calcium, and about 60% for the magnesium. So interestingly, the loop of Henle is where most of the magnesium is reabsorbed. And again, it's by a paracellular route, the claudin 16. Okay. 5 years ago, I would have said that nothing's regulated at this point, and I would have told you that both magnesium and calcium are regulated in the distal tubule. However, we do know that here there's a calcium sensing receptor. And it can respond to both calcium and magnesium, and clearly exerts some sort of control over what's going on in this cell. We don't know the details. So come back for a CME in 5 years' time and we'll figure out what it is. Okay? But we don't have a clear sense of how this is really regulated. We just know that these things are probably sensed at this point, and this cell can be turned on or off accordingly. Okay, so that's those two diagrams, right? See if there's anything I've missed out. Oh. So, I've got a note right at the bottom of the page. If you've got hypercalcemia, what would happen if you would give furosemide? Furosemide would block this, it would block this, and you'd lose calcium in the urine, yes? And so indeed, that's one of the clinical mechanisms for treating a hypercalcemia. Give furosemide, and it interferes with this system, and you pee out a lot of extra calcium. Okay? Yes, sir?
Would that be dangerous for the loss?
The question is, would that be dangerous for the loss of magnesium? Yeah. I'm going to say in general, whatever your calcium status and magnesium status are most likely to be similar, but you're right. If we have a hypercalcemia and magnesium deficiency, yeah, that would be an issue, wouldn't it? Yes, indeed. Yes. Okay. So, remember we did that case at the beginning? So Bartter syndrome, like a loop diuretic, interferes with the production of this fella. And so Bartter syndrome tends to cause loss of calcium and magnesium. Okay? Other things as well, potassium also, but tends to cause the loss of calcium and magnesium. And I know that this sometimes comes up on step exams. Okay, everybody good with those diagrams? Because I'm going to do one last diagram. Yeah, on the next page. So there's not much calcium or magnesium reabsorbed in the distal nephron. Let's see, at 67, 25, that's 85, 92. I think it says 8 on the diagram, but that doesn't add up, so let's call it 7. Does it say 8 on the diagram? Did I add it up correctly? Yeah. 2, yeah. That would have to be correct, wouldn't it? Okay, that last diagram. So now we're in the distal nephron. Okay, in the distal nephron, this is the thiazide sensitive area, remember? You got channels for calcium and you got channels for magnesium. These are both trip channels, and ask me if I'm going to test you on the numbers of the trip channels. I can't remember them, so I'm not going to ask you. So the magnesium is trip M6 and the calcium's trip V5. I had to look it up on my notes, so you won't be tested on it, okay? It's a calcium channel and it's a magnesium channel. They're trip channels. Okay. So we know that parathyroid hormone, when calcium's low, parathyroid hormone stimulates calcium reabsorption here. Okay? So it turns on some aspect of this trip channel. We don't exactly know where magnesium is controlled, but we think it's controlled here too. So there is an independent mechanism, we think, for the regulation of magnesium. But you won't find it in Costanzo, and you won't really find it anywhere. Okay? So we think that these are the major points of regulation. Realize too, this is the only part of the nephron where we actually have transcellular movement of magnesium and calcium. All the others are paracellular, yes? So this is the only place where we have channels that allow the passage of calcium and magnesium through the cell. So I think there's one more thing. Let me make sure there's nothing else I wanted to cover. Okay. Both of these fellas, well, thiazides inhibit this, and Gittelman's is a defect in this. Interestingly, thiazides can be given to increase calcium reabsorption. Doesn't make a lot of sense. It's not true for magnesium. Okay, so in Gittelman's, you have increased calcium reabsorption, and the reason that the resident had to check for the urine calcium is that you have reduced calcium in the urine in Gittelman's. Okay, so mechanistically we can't really tell you why, but it's one of these things in medicine you just have to know. So not only does Gittelman cause increased calcium reabsorption, but also thiazides cause calcium reabsorption. So if you want to hold on to calcium, you can actually give thiazides, and it will actually help to retain calcium. Don't give any other diuretic, or at least don't give a loop diuretic. That won't work. we used to give an explanation that something was going on in this cell. Okay, we've got time. I'm going to go through the old explanation. Let me use a different color pen. And this just kind of maybe makes it easy to remember. So the idea is that if you block this, and you're not bringing sodium in, the sodium will tend to come in this way, and you'll get calcium reabsorption. Okay, that's kind of an easy way to remember it. It's probably not true. It's probably an effect elsewhere, but that's kind of an easy way to remember it. Costanzo's smart. She doesn't tell you anything about how this might work because we don't really know. But if it helps you to remember, but you just remember that it's probably not true, that might help you, okay? You feel bad? You feel, I mean, we know it, empirically we know it's true, but we don't have a clear understanding as to why, okay? Are you frustrated by that? Okay. It is important because it's something that is of clinical significance. Okay, is that the last page? Yeah, okay. Let's take a break, and what we're going to do in the next hour is we're actually going to revisit potassium handling, and we're going to cover 2 or 3 different topics, and I'll explain those as we go along. Okay? So let's take a break. I didn't hand out any candy today, did I? Let's take a break, start again just before the hour. Okay?